The Skinstructors tip of the week. Did you know that post-inflammatory hyperpigmentation isn't just a concern for acne-prone skin? It can also show up after cosmetic procedures like lasers, peels, or even waxing, especially when the client's skin isn't properly protected afterward. PIH loves inflammation, so your best prevention tools are barrier repair, SPF, and downtime protocols.
Welcome back to the Skinstructors. I'm Morgan.
And I'm Jolie, and today we're doing a deep dive into one of the most common pigmentary conditions estheticians deal with, post-inflammatory hyperpigmentation, or PIH. We'll talk about what causes it, who's most at risk, how we treat it, and how to prevent it, especially in clients with deeper skin tones.
That's right. Jolie and I had the pleasure of learning from leading dermatologists in Chicago last month at the Pigment Disorders Symposium, and we're so excited to share with you all.
PIH, or post-inflammatory hyperpigmentation, is a discoloration that follows skin injury or inflammation. It looks like flat, darkened patches and is usually more noticeable in individuals with melanin-rich skin.
At the cellular level, when the skin experiences inflammation from something like acne, eczema, or an injury, melanocytes, which are the cells that produce melanin, they get triggered. They start producing extra pigment in response to cytokines, inflammatory messengers, and prostaglandins. They're like the body's 911 responders that accidentally go too far.
This leads to overproduction of melanin or its improper distribution. Sometimes that pigment stays in the epidermis, but it can also drop down into the dermis, which is when it becomes tougher to treat. A great way to figure out whether your client has pigment that's epidermal or dermal is by doing the stretch test. So what you'll do is you'll take that spot and you'll stretch the skin with your fingers. And if when you're stretching it, you can still see that pigmentation, that means it's in the dermis. If you stretch it and it disappears, that means it's epidermal, which is going to be easier for you to treat.
Thanks, Jolie. I love the stretch test. I think it's super helpful. And while it's not an exact science, I think it really is a great tool that estheticians can refer to. While post-inflammatory hyperpigmentation isn't necessarily a problem exclusive to acne, any inflammation from a rash, a bug bite, or even too aggressive exfoliation can lead to PIH, especially without proper post-care. Going beyond acne, PIH can follow a long list of triggers like atopic dermatitis, pseudofolliculitis barbae, viral infections like herpes or shingles, drug eruptions, and cosmetic procedures like chemical peels, microneedling, and laser rejuvenation.
And don't forget the role of medications. Common culprits include minocycline, antimalarials, chemotherapy drugs, and even overuse of hydroquinone. These can trigger pigment changes from within, either by stimulating melanocytes or depositing pigment directly into the skin.
Some drugs can cause melanin overproduction, while others, like minocycline, cause iron or drug deposits in the dermis, leading to stubborn discoloration. That's why a full client history, including medications and supplements, is so important.
Even herbal supplements like kratom, which many clients don't report because they don't think of them as drugs, can cause unusual patterns of hyperpigmentation.
And it's really helpful to understand the pathophysiology of PIH. Jolie, let's break down the root cause of PIH.
Inflammation is the root cause, but the downstream effects vary depending on how the skin reacts. In the epidermal layer, melanin accumulates due to stimulated melanocytes. This kind of PIH tends to appear brown and is more responsive to treatment.
In the dermis, pigment gets deeper into the skin, sometimes via damaged basal layers or leaking melanin into the dermis. That pigment becomes engulfed by macrophages, forming melanophages, which makes treatment a longer journey.
And let's talk more about the inflammation cascade that kicks all of this off. When the skin experiences trauma, a series of signals gets released. Interleukins like IL-1 and IL-6 tumor necrosis factor alpha, TNFA, leukotrienes, and prostaglandins. These biochemical messengers activate melanocytes and stimulate enzymes like tyrosinase, increasing melanin synthesis. At the same time, immune cells like mast cells and lymphocytes flood the area, which can exacerbate the process by releasing even more pro-inflammatory mediators.
To make it more complex, matrix metalloproteinases like MMP2 can break down collagen and disrupt the basement membrane, which allows pigment to leak into deeper layers of the skin. This results in what we call pigment incontinence, and that's when dermal PIH forms.
Its skin type plays a huge role. Fitzpatrick 4 through 6 skin has more active melanocytes and at a heightened response to inflammation. So a pimple that would fade in a few days on lighter skin could leave pigment for months in deeper tones.
And that's why prevention and cautious treatment are everything. We want to calm, not inflame.
When it comes to correction, we often look at topical treatments. Topical therapy starts with targeting melanin production. Tyrosinase inhibitors like hydroquinone, azelaic acid, kojic acid, and arbutin can all help brighten the skin by showing pigment synthesis.
Yeah, but brightening isn't enough. We also need to speed up cell turnover, and that's where retinoids, glycolic acid, lactic acid, and salicylic acid all come into play. They help exfoliate the pigmented layers and encourage fresh, even-toned skin.
And then there's inflammation control. Derms will often prescribe topical steroids in short bursts, and there are many other ingredients like niacinamide, all of which reduce triggers that lead to PIH in the first place. Other anti-inflammatory agents we love to include are green tea extract. It's rich in polyphenols that calm inflammation. Allantoin soothes irritation and supports wound healing. Panthenol or vitamin B5 improves hydration and reduces redness. Licorice root extract helps lighten pigment and reduce inflammation. And then bisabolol, found in chamomile, it helps soothe and calm sensitized skin.
Combination therapy is often best, so think retinoid plus azelaic acid or glycolic acid plus niacinamide. The synergy helps tackle multiple pathways.
And you guessed it, SPF, of course. UV light worsens pigment and makes all your hard work go to waste.
Energy-based treatments like lasers can help fade pigment, but they can also cause it. The key is using the right wavelength, fluence, and device based on the pigment depth and skin type.
Picosecond and Q-switch lasers are commonly used. The 1064 YAG is a favorite for deeper skin tones because it bypasses the epidermis and reduces the risk of PIH.
The endpoint should always be a subtle, mild erythema, maybe a slight whitening that resolves quickly. Aggressive treatments that cause crusting or bruising can actually make PIH worse.
And laser-induced PIH is real. That's why we must pre-treat high-risk clients with pigment stabilizers and post-treat with anti-inflammatories and SPF.
Absolutely. Combination approaches like low fluence laser plus oral tranexamic acid are showing great promise.
For darker skin tones, we love Cyton's Moxie laser. It's a non-ablative fractionated wavelength laser that creates microcoagulation zones in the skin. It's safe for all skin tones, and we have this laser at Boscal and have seen really great results with it. We also have the BBL Hero, which is a broadband light device that targets melanin in the skin. It's a great option for fits 1 through 4 skin tones.
I've had both of these treatments done, and they really helped with my pigment and also my texture. Julie, what about prevention? How can a client prevent PIH?
One of the biggest mistakes when it comes to prevention is skipping the skin prep. If there's active inflammation or a compromised barrier, you're setting the stage for PIH.
And another common error is stacking treatments without enough downtime. PIH thrives on repeated injury, so just let the skin heal.
Yeah, overusing exfoliants or combining too many actives at once can backfire. We see this a lot with clients self-treating at home.
Client education really is key. They need to know that post procedure redness or flaking is not the time to go sunbathing or skip sunscreen.
And for estheticians, it's important to manage client expectations early. Explain that PIH takes time, weeks to months, to improve, especially for dermal cases. Use before and after photos to show realistic progress. Remind clients that pigmentation doesn't appear overnight and it won't disappear overnight either.
Absolutely. Also, being upfront about the maintenance involved is really important. Treatment isn't one and done. Clients need to commit to consistent home care, strict sun protection, and follow up treatments. And when clients understand this from day one, they're more likely to stick with the plan and feel satisfied with gradual results.
A calm, protected, and nourished skin environment is the best prevention for PIH.
Okay, for your homework this week, take 20 minutes to review your treatment protocols for microneedling, chemical peels, and lasers. Are you prepping and post treating for PIH risk?
Check your retail recommendations too. Are you sending clients home with pigment inhibitors, inflammation calmers, and most importantly, sunscreen?
If not, update your plan. Prevention is your best pigment strategy.
Tag us at SC Training with your updated protocol or PIH prep shelfie. We want to see what you're using.
And as always, reach out to us with any of your questions or share your own experiences. You can DM us on Instagram at SC Training. We love hearing from you.
And don't forget to subscribe, rate, and review. And as always, don't hesitate to educate.